So I'm going to talk about the recommendations with the biggest emphasis on the age for routine recommendation of HPV vaccination. Next slide, please. So in July 2020, a little over a year ago, the American Cancer Society issued our updated recommendations for HPV vaccination. And I'm gonna go through those, but with a focus on the first one. And so the first one says girls and boys should get 2 doses of HPV vaccine at ages 9 to 12. And that is slightly different than what we said before, which was more of what the ACIP/CDC said, which was routinely vaccinate at age 11 and 12 or starting at 9. So that's the big change. This second one is the same as the ACIP and CDC. ACIP stands for Advisory Committee on Immunization Practice, and they set the guidelines for CDC for all vaccines for the United States. And so the second recommendation was just bringing male vaccination to have the same language as female for catch-up, which means that for those who did not get vaccinated at the routinely recommended age, they still should get vaccinated up to the age 26. The American Cancer Society continues to add the caveat that vaccination of young adults will not prevent as many cancers as vaccination of children and teens. So if somebody didn't get vaccinated on time, absolutely they should get vaccinated. But if you have a choice of vaccinating on time or delaying that, I'll give you plenty of data on why you should recommend on time. And then finally, the American Cancer Society does not recommend HPV vaccination after the age of 26. The ACIP and CDC say that also this is not recommended. However, for those ages 27 to 45, they have the option of patients have the option of discussing HPV vaccination with their provider and coming to an informed decision about whether or not to get vaccinated. Next slide. So I told you I'm going to be emphasizing that first recommendation of routine vaccination at age 9 to 12, and I'm going to talk about the reason for that. Next slide, please. And so here's the exact language from the ACS guideline. Providers are encouraged to start offering the HPV vaccine series at age 9 or 10 years in order to achieve higher on-time vaccination rates, which will lead to increased number of cancers prevented. So I will show you the data on how I know that this will increase the number of cancers prevented, because it will increase on-time vaccination rates. It's not that the vaccine is more effective at preventing cancer in a child that's vaccinated at age 9 compared to a child vaccinated at 11. It's a programmatic issue in which if you're only going to prevent cancer if you actually get the shot into the arm. And that's more likely to happen for 9 and 10-year-olds than 11 and 12-year-olds. And that's more likely to happen than 13 and 14-year-olds, which is more likely than 15 and 16-year-olds. Next slide, please. So I promised you some data. There are references, there are specifically cited articles throughout the ACS guideline on this, and I'll direct you to other areas where you can find these. But I'd also like to talk a little bit about at least one of the many case studies. And so these are, I think, where I hear the most excitement, is when I hear from someone who's actually in their system made a change and improved their vaccination rates, and credited the vast majority of their success to recommending at age 9 instead of waiting until age 11. And so this example comes from New York City Health and Hospital Systems. And if you look at the next slide, these two systems in New York, one in Queens, one Gotham, this shows in the darker color the increase in initiation of HPV vaccination for ages 9 to 13 during the 1-year intervention, so between 2019 and 2020. And this does include COVID, so they were able to increase rates even during COVID. And you can see it's a pretty nice increase. That's one that a lot of people would be happy to see. And then the lighter color is the increase of completion for 9 to 13-year-olds. So you can see on the left about a 20-point increase, 25% increase almost in initiation, and similar numbers on the right, actually a 60% increase in initiation and 40% increase in completion. So those are great numbers. When we asked the leads for this this intervention, the leads for the systems that did this intervention, what do you attribute the success to? If you'll go to the next slide, these are direct quotes. So what's been the most impactful change you made? And the answer was routinely initiating HPV at age 9. So that's a pretty compelling argument there for doing nothing different other than starting to routinely offer vaccination to your patients at age 9. That doesn't mean you stop giving it at age 11, 12, but if you introduce it at 9, you too may see the huge success that these systems saw. And in addition to initiating at 9, they talked about normalizing it at an early age, and also presenting the vaccine as cancer prevention. Next slide, please. So why does this make a difference? Why would simply changing the age to start offering vaccination from age 11 to age 9 make such a huge difference to so many different health systems and providers? And what the literature tells us and what the experiences of many of these systems tell us is that you vaccinate early, you have more time to complete. So if a child comes in at 9 and you don't see them again until 11 or 12, you've had more opportunity, you've had 4 years instead of 2 years. If there's a pandemic and a lot of people are delaying their healthcare visits or going to online visits where you just can't give a shot by video, then you have more opportunities. You also do increase the likelihood of vaccinating prior to first HPV exposure. No one wants to think about a 12-year-old being exposed to HPV through sexual contact, but unfortunately, sometimes that does happen, and it's a lot less likely to happen for the 9-year-old. Now, we recommend not talking about sexual activity when we talk about the HPV vaccine, particularly for preteens. And we don't talk about how people get, how viruses are transmitted for any other vaccine preventable disease. But nevertheless, parents often do bring up sexual activity when the HPV vaccine is offered to the average 11 and 12-year-olds. And for whatever reason, it doesn't come up in the visit for a 9-year-old. And so even though it's not recommended, it happens, and recommending at age 9 makes this a little bit better. We also have decreased requests for just those vaccines that are required. So a typical comment from a parent might be, the doctor says, okay, your child is due for these 3 vaccines today, and the parent might respond, I only want the ones that my child needs, has to have in order to go to school. Well, most states require Tdap and or meningococcal at 11 and 12, and very few states require HPV. And so what you have is a parent leaving with their child, with their 11 and 12-year-old child, being protected against Tdap and meningococcal, but not HPV cancers. If you offer HPV vaccine and it's accepted at age 9, and they come back at age 10 and get their second dose, then at age 11 and 12, they can just stick with Tdap and meninge, and they'll be fully protected against each of the diseases. So a lot of systems, like the New York systems that I just showed you, have had success in increasing vaccination rates when they routinely offer HPV vaccination at age 9. And those studies, those published studies, have also shown that the systems find it acceptable, that the providers find it acceptable. And on the next slide, you'll see that from the parent and patient perspective, they also find this acceptable. They also like to avoid talking about sex. That's not something that providers or parents or 11 or 12-year-old kids want to do in the exam room. And in addition, there's more and more data accumulating that parents seem to have a limit of 2 shots per visit for their kids. And so if you're gonna give Tdap and meninge, which are the ones that are more likely to be required and that parents are more likely to choose if they're only going to accept 2 out of 3, then that's your 2 doses, 1 in each arm. And if you vaccinate with HPV at age 9 and give the second dose at age 10, then that's 1 less shot that they need at 11 or 12. And so all of these add up to a lot of benefits to vaccinating routinely at age 9 and 10. And if you go to the next slide, there really is no downside. When the vaccine first came out over 15 years ago, this is not a new vaccine, but 15 years ago, and even longer when we went through the process of making the recommendations, we didn't know at that time how long HPV vaccine would protect kids. And so there were some concerns about, well, if you vaccinate too early, then their immunity might wear off. Well, that hasn't happened. And it's looking like nobody will need a booster. If anything, we've went from 3 doses to 2, and there's more and more data saying maybe we'll get to just 1 dose. So this protection is not waning over time. That was the only potential downside. Next slide, please. Well, how about this confusion about, well, you've just told us one thing, but you said that ACIP and CDC say something else. Well, the American Academy of Pediatrics in 2018, so 3-4 years ago, recommended starting HPV vaccination at age 9 to 12, which is exactly what ACS says. And a year later, in 2019, they published an article with the title, Why AAP Recommends Initiating HPV Vaccination as Early as Age 9. And now they're getting rid of that as early as language. That's not the preferred language. And they're updating all of their materials. The preferred language is vaccinate at the earliest opportunity. The earliest opportunity for HPV is age 9, because that's when FDA license begins. That's who was part of all the clinical trials many years ago. Next slide. And we're not inconsistent with the ACIP and CDC. They do allow and have always allowed vaccination starting at age 9, but their language is just a little bit different. So they say it's routinely recommended at age 11 or 12 or starting at age 9. So again, it's consistent, but we'd like to have more consistent language. And you're going to be seeing more from ACS and AAP on this 9 to 12 and earliest opportunity. Now, why do ACIP and CDC say, why are they sticking with 11-12? They put a lot of effort and a lot of funding and a lot of time into promoting an adolescent platform for vaccines. The problem is that it didn't take into account that parents and kids at this age don't want to have 3 vaccines in one visit. So if vaccinating at 11 to 12 is working for you and your rates of HPV are as high as your rates for Tdap and meninge, then go ahead. And if you want to keep doing that, keep doing that. But if your rates of HPV vaccination, and I really hope that you know your rates, because that's one of the first recommendations if you're looking to increase your vaccination rates, is to know your data, know your starting point. But if your rates are not as high, which is the most common situation, then go ahead and give this a try and see if it works for you. Next slide, please. And again, if your own children or the children of your patients didn't get vaccinated by their 13th birthday, then absolutely go ahead and vaccinate them. If the first dose was given before the 15th birthday, they need 2 doses, regardless of when the second dose is. So if the first dose was at age 14 and they don't come back again until 18, you still give them that second dose at 18 and they are done. If the first dose was given after the 15th birthday, then they need 3 doses. And if they're immunosuppressed, they need 3 doses, regardless of the age. Next slide. And I did mention that the ACS does not recommend mid-adult vaccination, which is defined at age 27 to 45. Next slide. I'm not going to go into too much detail, but one of the things I like about this slide and these data is that it makes 2 points. One is you need to vaccinate on time because that's when the vaccine is most effective. And the second is that by the time you reach adulthood, for most people, this vaccine really is not effective. And we don't know how to identify the few people for which it is effective. So 99.6% of people won't benefit from mid-adult vaccination. And that counts, when I say it won't benefit, I mean by detection of cancer, prevention of cancer, by prevention of precancer, prevention of genital warts, and prevention of HPV infection. So what this slide shows is that in some countries where they have these fantastic registries, and you can look at if person A was vaccinated at age 12 and then comes back to get screened for cervical cancer at age 21, what's the likelihood that they'll have an advanced precancer? And the answer is, if for anyone vaccinated at age 12 or 13, that vaccine is 86% effective. And that was with the bivalent. That was before we had the 9-valent. If a group of people were vaccinated at age 17, and in this case, we're looking at cervical cancer, so we're just looking at females. If vaccination was at age 17, then effectiveness against cervical advanced precancer or cancer is down to 50%. And then if vaccination occurred at age 18, 19, 20, which didn't happen that much in these countries because they were mostly vaccinating on time, then effectiveness was down to 15%. So if you ask me what do I think about vaccination of adults, I ask you, look at this data and tell me, what do you think the effectiveness is going to be for vaccination at age 30 or 35 or 40? Next slide, please. And here's another slide that makes 2 different points. One is vaccination on time prevents cancer. So for many years, we only had proof that vaccination prevented advanced precancer. We knew that in order to get cancer, you have to get precancer first in the case of cervical, vulvar, vaginal, penile, and anal cancers. So 5 of the 6 cancers that are prevented by HPV vaccine. We don't know that for oropharyngeal cancer, which is the throat and base of the tongue, because that cancer does not have detectable precancers. So in Sweden, where they vaccinated 1.7 million females aged 10 to 30, what they saw is 88% protection against invasive cervical cancer before age 30 when vaccination happened before age 17. Almost all of those vaccinations were actually on time, but this is how they stratified the data. So you can see in ages 10 to 16, there were over 400,000 females vaccinated and only 2 cases of cancer by age 30. Whereas about 1/5 as many females were vaccinated after age 17, and there were almost 10 times as many cancers in that 1/5 as many people. And then vaccination, again, at a later age is just going to be much less effective. So the next slide is from the same study. That orange line is no vaccination. The green line is vaccination before age 17. And this is showing you prevention of cancer, prevention of cervical cancer. The blue line is late vaccination. And so again, 2 points. 1, HPV vaccination does prevent cancer. It is proven. There is no longer any argument that anybody can make that, well, you don't know that for sure. We now know that for sure. And the second point is that when you vaccinate on time, you get much higher protection against cancer than when you vaccinate late. Next slide, please. All right, so let's move on a little bit. Next slide. The 2 questions that I most often get are, does this vaccine work? And yes, I've just shown you it does. And is it safe? So next slide is another slide that's showing you these high-grade precancers. And if you look in the red circle, you can see the year that the vaccine first came out, and how common were cervical precancers in the US before vaccination. And then the light blue line is in the years after vaccination. So this was back in 2016. We didn't even have that high rates of vaccination, but you can already see a dramatic decrease. And then the next slide is the same study from Sweden that I just talked about. Next slide, please. So we know that we can prevent over 90% cervical cancer through vaccination. Next slide, please. And then the next question I get is this vaccine safe? And so absolutely yes, but let me show you a little bit of data. Next slide, please. And so this is actually not the most recent of slides. So we have well over 10, probably over 15 years of vaccine safety data, maybe even going on 20 years. And they've looked at everything. If you look at that second to last bullet point, over 60 other conditions in addition to all the ones that you've probably heard about. And every single study shows that there is no safety issue for any of these conditions. Next slide, please. And to sum it up, and this is a paper from 2018. So again, it's not the most recent, but 109 studies, which is a lot more now, of 2.5 million people, again, a lot more now, in at least 6 countries, have all shown no serious side effects. Let me say that again, no serious side effects, other than for people who are allergic, which would happen for any vaccine. And let's face it, teens faint. Most of the time they faint at the site of the needle and not what's actually in the needle. And fainting can be a serious side effect if, for example, the person getting vaccinated who faints hits their head. So next slide, please. So let me show you just a few of the many resources. And over the next few slides, I think the last of them will show you where you can find all of these in one place. So one-stop shopping. Next slide. And again, just to highlight a few, a lot of people are really concerned about the impact of COVID on vaccination, on all other vaccination, but particularly teenagers. And so we did develop, we meaning the HPV Roundtable, the National Roundtable, did develop a bunch of materials for health systems to get their vaccination rates back up. Next slide. The Roundtable also has a YouTube channel with playlists for parents, for health systems, for providers. So I encourage you to go to HPVRoundtableTV.org. Next slide. And you can get any resource from the Roundtable, from the Cancer Society, from other states, from CDC, from the American Academy of Pediatrics, and many others at the HPVRoundtable.org website. There's a tremendous resource library. It is the most popular site on any given day, the most popular area of the website. And you can filter it, you can sort it, you can add to it if you have resources that you would like to appear on the library. Next slide, please. All right, so I'm going to sum up here and hopefully leave some time for questions. I think I'm preaching to the choir here that you all know vaccines save lives. You hopefully all know that HPV vaccination can help prevent 6 cancers. We can only screen for one of those, cervical cancer. We can't screen for the other 5. And even with cervical screening, we don't find all cancers. And we do, most of the reason why screening is so effective for cervical cancer is that it finds advanced precancers, but those have to be treated, and that has significant morbidity as well. And so we still need vaccination. Vaccination rates are too low, particularly for HPV vaccination. And we absolutely know we can get them higher because we know that we have much higher rates of Tdap and meninge. So these are parents bringing their kids in at the recommended age, leaving the doctor's office or health department with 2 out of 3 of the vaccines. So hopefully if we can vaccinate more at age 9 and 10, then that will really help. We also know that if we vaccinate against HPV and screen, that we will decrease cancer disparities, because cervical cancer, as an example, is just the poster child for cancer disparities. We know that parents value HPV vaccine. We have many surveys that show this. And we know that all of us and all of our children are at risk for getting HPV and for getting any of the 6 HPV cancers. Next slide. And so if I give you a call to action, it would be to talk about HPV vaccine the same way you talk about every other vaccine, to talk about it as cancer prevention, and to start routinely offering it, if you're not already doing that, at the first opportunity, which is age 9. And so I'm happy to answer questions.
Well, thank you, Dr. Saslow, for a fantastic presentation, and more important, for the incredibly important work that you do, and the thousands of lives that have been saved already. Maybe I'll start out with a couple of questions and then we'll open it up. First of all, has there been any discussion of combining the HPV vaccine with other vaccines to reduce the number of pokes and maybe to increase the acceptance on the part of some folks who are hesitant for this particular vaccine?
I would say not that I know of. If there's anyone from Merck on the line, I think I saw someone, but I don't think so. And I would not be optimistic that that will happen. I think if anything, that they would try to get more types of HPV in the vaccine, and that's really hard to do. So when the vaccine went from 4 types to 9 types, that was not easy to do and to scale up. And so I think it would probably be too difficult to try to combine even more vaccines into one shot.
And then my second question is, given the public's increased awareness of vaccines, do you see how the debate over COVID vaccines is going to either help or hurt our ability to vaccinate more kids?
From what I'm hearing, most people are concerned it will hurt more than help. It has just gotten so politicized, just vaccines. Also, the topic of school requirements for vaccines has been put at risk. I mean, it'd be nice if it would if it would help, but I think we'll be lucky if it stays the same.
Okay, thank
That's
you.
my personal opinion. I hope I'm wrong.
We'll see. Let's see. I think Aaron Shearer has a question. Aaron, would you like to unmute and ask your question?
Yeah, so I find your arguments for vaccinating 9-year-olds totally compelling. One thing I was wondering was the opposition to vaccinating adults. And my understanding of the argument for engaging in shared decision making with adults who might benefit from the vaccine is that presumably it's for adults who have been in a long-term relationship and might be initiating new having sex with new partners, which would make them more analogous to vaccinating a 9-year-old or 11-year-old because they've gone for a period without exposure. And so I was just wondering if you could comment on that, in addition to the fact that given that there's no serious side effects, it seems like even if it's only 15% effective, that's better than like nothing for adults.
So it's 15% at age 18 to 21, down from 50% at age 15, down from 85% at younger ages. And so the number is exceedingly small. I, as a representative of the American Cancer Society, I speak from a public health perspective. We would not want to give millions and millions of people vaccine when it can help one or two or less than 0.5%, and we don't know how to find them. This is one way to specifically look at this population that you put in the chat box, and that is the intention of shared decision making. However, the amount of effort that would need to go into identifying people and having this conversation, the likelihood, most of the people in my experience and from what I've heard who would be asking are women, and most of them in the 27 to age 45 group are the same group that have children in the 9 to 12, just looking on average when people have kids. And so the risk of having a conversation with a parent of a 12-year-old and saying, for you, tell me about your sex life, tell me about your exposure, tell me, how many sex partners have you had and what's going on here, and this is why or why not I think HPV vaccination might be helpful for you. And for your child, it's all about cancer prevention. It's not about sex. We don't want to be talking about that. So there are these unintended consequences that might happen. That's one example of the downside. And so my advice is, if Iowa can get their HPV vaccination rates on time by age 13 up to 90%, where you are with Tdap and meninge, and you want to put an effort into adult vaccination, go ahead. If a person aged 27 to 45 comes to their provider and says, I'm interested, I want to know, this is my situation, I'm fine with them saying, yeah, this can't hurt. But my experience in talking to a room full of gynecologists, of hundreds of gynecologists at one time, and asking them, raise your hand if you're, vaccinating adults, and I'd say 99% of them raise their hand. So they're going way overboard. I don't think that this informed decision making is working the way it was intended to work. So I will say, yes, it's safe. And if a provider and a patient feel that they would benefit, that's fine. But from a public health perspective, which is how we do guidelines, it's let's focus on when the vaccine is going to be effective.
Mm-hmm. Yeah, I totally agree with you. Like the focus should be on early vaccination.
Yeah.
So totally on board with you there.
So I see Liddy Hora is in my little Zoom box here, and Liddy obviously is very involved also nationally in HPV, but also knows the Iowa Cancer Consortium quite well.
Right.
Liddy, what else can we do as a consortium to assist in this efforts? Do you see that there are any weak spots where we can really gear up our efforts in this regard?
Thank you for asking, and it is nice to see a lot of my good friends here from Iowa. I am, as about 8 months ago, joined the HPV Roundtable team, but of course have had quite a few years of experience in Iowa working with a lot of large systems. So to answer your question, I think what Iowa Cancer Consortium can do is to continue this. You can be a very strong voice and leader and be very influential to all large systems, clinics, our primary care, our pediatric, of sharing this information, engaging our systems and our physician champions, and trying to get in the same language. I think a same language, shared language, is very, very important. When we had our national meeting in July with the roundtable, we had over 400 plus people from across the nation join. And through our polling was a very strong interest that said our states, including Iowa, are very interested in having re-engaged engagement with our state coalitions. So I think our states are ripe for that leadership. They're wanting to be re-engaged. So I think Iowa Cancer Consortium can really play a very strong role in this re-engagement and having a common language around first opportunity at 9 and why this can be so effective, because Iowa doesn't have our HPV rates at our Tdap and meningococcal. We're not at that 90%. And so we do have room for growth and opportunity to get more vaccinations in kids' arms.
Thank you, Liddy. Georgia Hodge, who's a member of our board, has a question as well. Georgia?
Are there any known disparities in the vaccination rates?
Yes. The main disparities are geographic. So probably the most well studied and documented and reported are the disparities between individuals living in rural areas and those living in metropolitan areas, urban areas. Nationally, there are higher rates of vaccination in non-white and low-income populations for the first dose, but lower rates for completion. So that's the national landscape. What we know locally is that there are disparities at the county level, at the local level, state by state. And so, just because we may not see certain racial differences or ethnic differences or income differences at the national level, we do know they're there. But that's a little bit harder to document. It's harder to get the data. So, if Iowa has county by county data, provider by provider data, system by system data, that's really helpful to look at, to get at where the disparities are.
Okay, well, Dr. Saslow, thank you for a spectacular presentation and great discussion.
All right. Hello, everybody. Welcome back. My name is Liz Orton. I'm an outreach coordinator with the Iowa Cancer Consortium, and my pronouns are she and her. We recently hit a milestone of 500 members, which is the first in Iowa Cancer Consortium history. So with over 500 members across the state of Iowa, it's hard to know who everyone is, where they work, and their areas of expertise. So this week we're piloting a Meet the People of the Iowa Cancer Consortium segment, which gives a few members the chance to share a bit about themselves, their work, and their goals. So our first member who's going to be sharing is Jason Sempridi. So everybody, please welcome Jason. And Jason, we made you a co-host if you'd like to share your screen, but go right ahead. Welcome.
Hello, everyone. I'm Jason Semprini, and I'm a PhD student at the University of Iowa College of Public Health. Here's my daughter, Shalai, and I'm also an NIH research fellow there. Formerly, I was a Susan G. Komen Cancer Disparities Scholar at the University of Chicago, and that's where I really became passionate about identifying and addressing some of the systematic causes of cancer disparities, especially racial and rural disparities. Typical day for me is pretty dry. I do a lot of reading and data analysis. Sometimes I do some writing. I should do more than I do, but that's usually the end goal. But the most fun is when I get to present some results and have some meetings with some of the actual people on the ground doing some of the care provision or the policy making. I'm also a member of the Iowa Cancer Consortium Rural Work Group, as well as the Iowa Public Health Association. As you can see, we are repping the public health today. And some nationally, I'm involved with the American Association of Cancer Research and American Society of Clinical Oncology, as well as a state collaboration called the Iowa Rural Cancer Collaboratory. I was asked to describe an issue or trend that is that I think that is not only of interest to me, but I think is just a major issue across the state and the country. And I think that is of health disparities and cancer disparities in general, specifically racial, but also other dynamics such as rural or gender identity and sexual orientation. The outcomes, this isn't a new issue, but it is still unresolved that there are poor outcomes for some of these more either minority or disproportionately affected groups. And a trend that I think is on one side good is more interest in health equity work, health equity research, health equity programming. But that it's also creating another issue. And so as more people get involved in health equity, we need to make sure we're doing it right. And that's not just basing our research and programs and evidence and science, but forming and establishing and maintaining partnerships with the people who are doing the work on the ground and the people who are experiencing these disproportionately poor health outcomes. I think that is maybe the next step that we all need to consider taking. My focus right now is on grants. I'm writing an NIH grant to fund my future research on head and neck cancer disparities and how maybe Medicaid and health policies can improve those outcomes. But I'm also working with some small rural hospitals across the state, trying to help their grant programs build up the capacity of their work so they can continue serving their local constituents. And yeah, I appreciate the time to share a little bit about myself and look forward to the rest of the conference.
Thank you, Jason, and thanks to your daughter too. Thanks. All right, and next up we have Gia Wei. So Gia, I will share your slides, and then if you want, you can turn on your camera, but here we go for Gia.
Hi, everyone. My name is Jia Wei. My pronouns is she, her, hers. I am an MPH in policy student at College of Public Health of University of Iowa. Now I am doing my practicum with Rachel at Iowa Cancer Consortium. Thanks again, ICC, so much for having me here. And I come from a very beautiful coastal city in China called Ningbo. If you have a chance to visit there sometimes. Before I came to Iowa in 2019, I was a speech language pathologist and have 4-year work experience. As you can see, I I turned to public health from rehabilitation therapy. You probably wonder the motivation. I will tell you later. I devoted myself to exercise and health-related activities almost 3 times a week for being robust because I love travel and photography, walking around and carrying big camera are all physical work. But now I turn to a small camera, not an excuse for avoid the physical exercise. And those are the pictures these are the pictures I took at Chicago O'Hare International Airport, and those are the night view of in our city. And this is snow view in our city. I love those. I love the snow view in our city most because I didn't see such thick snow ever in my life. And I just mentioned that I turned to public health from rehabilitation. When I was a speech language pathologist, most of my patients are elderly with stroke. My major responsibility is assessing their speech and language function through assessment scale and other technical exams, and also carried out training for them. Most of the time, patients who suffering severe stroke get limited improvement even after 1 year treatment, which make me realize how important the disease prevention is. Public health helps detect health issues as early as possible and responds appropriately to avoid the development of disease. That is the key reason that drives me to public health. Next slide. This is one of my projects that focuses on breast cancer, which helped to draw a vague peak on breast cancer and the behavior risk factor surveillance system database, which is a key role in public health investigation. I was brought in our cancer consortium probably because of this cancer investigation experience. And next slide. The consortium investigates members' opinion about their members about their membership every 2 years. This helps us to know how satisfied members and what they are looking for. For my practicum project, I will be working with the rural cancer work group members' enthusiasm for advancing equitable cancer control strategies and building member capacity around policy systems and the environmental change. Some information will be gathered through ICC's member system via the Apricot. If you haven't logged in, this is the link. Go for it. Now I am doing my practicum on developing member survey and is going to test it after finalizing it. I also wish to get a chance to interview some of you and hear more feedback from you. And I'm going to graduate this December. In the future, I hope my healthcare and public health working experience, policy analysis, related ability, and basic data management skills could lead me to do more for the cancer prevention. Nice to meet you all. Thank you.
Thanks, Gia. All right, and now to introduce our next speakers, please welcome Iowa Cancer Consortium board member, Dr. David Dickens. Welcome.
Thank you. Can you hear me okay?
Yes.
Great. I'm coming from our clinic up here at Stead Family Children's Hospital. As you can see, we've had a nice cleanup after a very exciting weekend. I am a pediatric oncologist. I have been for about 20 years, and I'm currently the interim division chief at Stead Family Children's Hospital for pediatric blood disorders, cancers, and transplantation. And it's really my pleasure to introduce the final session for today, which is HPV vaccinations in Iowa. Where do we stand now? and what needs to happen. This is from Dr. Natasha Alkelson and Dr. Aaron Scherer. And in many ways, I feel like my career has given me similar responsibility as these two members, as I've had to adapt a fair amount of behavioral engineering in my practice. And these two speakers have expertise when it comes to choice architecture in their respective fields. Dr. Natasha Alkelson is an associate professor in the College of Public Health, Department of Community and Behavioral Health, with an adjunct appointment in the Health Policy Research Program at the Public Policy Center. She currently serves as the PI for Iowa's Cancer Prevention and Control Research Network, collaborating Deputy Director of the Prevention Research Center. Dr. Alkelson is a member of the Holden Comprehensive Cancer Center, and her research is focused on understanding how evidence-based interventions can be implemented in rural areas. She has extensive expertise and experience related to uptake of the HPV vaccination and currently spends much of her time working on increasing COVID-19 vaccination in Iowa. Our second member that will be speaking today in our final session is Dr. Aaron Scherer. Dr. Scherer is an assistant professor of internal medicine at the University of Iowa Carver College of Medicine. Dr. Scherer is a social scientist with a research program focused on identifying and utilizing insights from the psychological sciences to create and evaluate innovative risk communication-based interventions to improve the appropriate utilization of preventative healthcare services, such as vaccination screenings. He currently serves as the PI for a CDC cooperative agreement to survey healthcare providers and the general public regarding vaccine policy-related topics, and a National Institute on Aging project collaborating with older adults with low vaccine confidence to create novel vaccine messaging. Dr. Scherer is also a co-investigator with Iowa's Cancer Prevention and Control Research Network Collaborating Center and an affiliate member of the Holden Comprehensive Cancer Center. Everybody, please welcome Dr. Alkelson and Scherer.
Thank you so much for that introduction. Can everyone hear me?
Yes.
Perfect. Okay. So welcome to the first day of the Iowa Cancer Summit and what appears to be the first day of fall. I know some folks might not be super excited about all of the rain, but I tried to dig in some lily bulbs this weekend, and I'm excited that it might actually be possible next weekend after some rain. So my job today is to dive a little deeper into the concepts that Dr. Saslow presented on and really connect them to our situation in Iowa. And then kind of set the stage for some really exciting data that Aaron Scherer will present on. So both Aaron and I would like to recognize our funding. We would not be able to do this work without it. And recognize all the faculty and staff that we work with. On the next slide. And on the next slide, all of our partners. So we've been very fortunate to have partners both at the state level as well as nationally to work on these issues. Next slide. So we're going to start with some really basic information about where we stand with HPV-associated cancers, which is the whole reason that we care about HPV vaccine. So next slide. So take a look at this. On the right-hand side, you're going to see all the cancers that are identified as being associated with an HPV infection. And then on the left-hand side, you see a map that shows Iowa and the HPV-related cancer incident rates that are age-adjusted from 2014 to 2018. And a darker color is a higher rate. So kind of locate your county where you live or work and see how you fall out. So you see we have a few areas that have some pretty dark counties. We got a lot in that mid-green range. Next slide. So this takes that and breaks it apart a little bit for us to really understand what's happening around HPV-associated cancers over time. And so the lines represent age-adjusted incidence rates. And sorry that looks like there was some formatting issues in the conversion. That purple line is cervical cancer, and you can see that it's gone down over time, and certainly would like to attribute that to Pap tests, those good old Pap smears and that screening. That blue line, that kind of light blue line, is a male oropharyngeal cancer, or OPC, and that rate has steadily been increasing over time. The red dashed line is female associated HPV cancers that are not cervical cancer. And then that green dashed line is male cancers that are not OPC. And so you can see we've got some good news and some very concerning news. I think the take home here is we hope that this graph looks very different in 5-10 years after we have seen a lot more HPV vaccinations. Next slide. So let's talk a little bit about the vaccine itself. Dr. Saslow mentioned some of the kind of more recent events that have been interesting. So if you haven't been following the vaccine as closely as some of us do, there are two things that I just want to highlight for you that might be different. If you go to the next slide, you can see for some of you who haven't been engaged in HPV for a while, you'll remember it used to be 3 doses, but we've moved to a 2-dose schedule, which is great, a lot easier to get those doses in. And as Dr. Saslow indicated, there is some evidence that we may at some point in time be able to go to a 1-dose, which would be even more exciting. And then we have those older folks, the 26 to 45, who could potentially receive the vaccine with shared decision making. If you go to the next slide, this has been really exciting for us. In 2018, the American Dental Association released a policy urging dentists to support HPV vaccine as a way to prevent infections that were associated with oral pharyngeal cancer. And then finally, in 2020, the FDA agreed that the vaccine did in fact prevent OPC. And so we're very excited to be able to talk about that as another cancer that the vaccine can definitely prevent. And it also opens it up to other set of healthcare providers that we can talk to about the value of this vaccine. Next slide. So what does the vaccination look like at Iowa? You saw some national data, but let's talk about Iowa specifically. So if you go to the next slide, the national data that we have is related to a survey that happens yearly, where they do take a representative sample of folks and try to figure out what the vaccination rates are. In Iowa, we're very lucky. We have a really robust immunization registry information system called IRIS for short. And this will allow us to look at vaccination rates without having to do things like do surveys that are very expensive and don't necessarily give us all the data we need, or chart audits, which is what I started my career in public health doing, which we used to have to go to doctors' offices and have charts pulled. So this is a great resource. And so we want to be sure you all know about this resource and also know that you can access it on the Iowa Department of Public Health's dashboard. You can pick different vaccines, you can pick different years, you can pick different age groups, and then look at trends over time, or just look at how your county is doing. But this is a really great resource that we urge you all to do and take a look at. We are very fortunate to have this kind of registry. So many, in fact, the majority of states do not have this kind of registry. So it's important that we use this data that we have available to us. Next slide. So we kind of taking the data that Debbie was talking about and breaking that down even more. So this is as of June 2020. And we don't have more updated data because clearly we're in a pandemic, and the folks who work in the immunization registry are also the same folks working on COVID-19 vaccines. So these are very busy people. What you can see here is we broke out 11 to 12-year-olds and then 13 to 15-year-olds. And you see 11 to 12-year-olds don't have amazingly high rates. The highest we're coming in at is urban females at, almost 30%. And the lowest is for rural males at 21.5. So not great for 11 to 12-year-olds. If you go down to the next row, whoops, sorry. Next row, next slide, next row. We about double, which is great. But we're nowhere near the 80%, which is the Healthy People 2020 and 2030 goal, or the 90% that we see with Tdap and meningitis, which are the other like co-administered vaccines. So keep this in mind. The disparities were talked about previously. And one of the unfortunate things in our immunization registry is that we have missing data around race and ethnicity, to the point where we're not really able to draw out many conclusions related to what we might see in terms of differences. It's a very similar issue that we see in the Medicaid data. We've actually looked at HPV vaccine in the Iowa Medicaid data and had a similar problem because we have a large proportion of the race and ethnicity variable is missing. We're not able to kind of talk about those disparities in a way that we wish we could. Next slide. So the next few maps illustrate kind of changes that you can see over time as a kid ages. So this looks at 11 and 12-year-olds, and you can see the darker the color, the higher the rate. And our highest county rate is 34.3% for 11 to 12-year-olds. So keep that in mind when we're talking about wanting to vaccinate 9 and 10-year-olds. We have got a lot of work to do. This is someplace we need to put some energy. And if you go to the next slide, you can see for 13 to 15-year-olds. And there we make a bit of a jump. Again, darker colors, higher rates. And we're getting up to a county with 74.2% for the highest rate. And we have a map that I don't have in here, but shows 17-year-olds. And once you kind of get up to 17, we're doing a lot better. But again, based on what we just heard before, we want to get those kids vaccinated earlier, and waiting until they're 15, 16, 17 is really too late. If you want to go to the next slide, we break things down by zip code. So one of our frustrations, I do a lot of rural research, is that our counties are kind of arbitrary, right? They're like lined up like lines, and they're political boundaries, but they don't really do a good job of necessarily highlighting the diversity we have in our state, both in terms of rural, urban, and in terms of populations. But at the zip code level, we can look at that a little bit more. So here you see HPV initiation rates at the zip code level. So you can all kind of try to identify your zip code, which is a little harder to do, or the zip codes where you work. The darker outlined zip codes are our more urban or metro areas. And the darker the zip code is, so the dark green, those are our highest vaccination rates. These are for 13 to 15-year-olds. And so we get, we get vaccination rates up into the 76 to 100%. So we've got some zip codes that are doing really well. The red is in like stop, caution, pay attention. Those are the ones that we're very concerned about. Those are 0 to 25% of kids in this age group have initiated the vaccine. And then you can see there's these yellow patches that we think need some attention. So that southeast corner of the state, that little part of the state where it like makes a nose with the Mississippi on the east side. We've got some concerns in kind of the central north and a little bit in that western part. So these are all places that need our attention and that you can't necessarily see when you look at the county level data. So if you go to the next slide. So we have this really great vaccine, but we're not seeing a lot of uptake. And there has been a lot of research on why that is. And there have been many evidence-based interventions developed that will help move the needle. But there are two challenges right now that I think we're facing that I want to highlight that I don't think have gotten enough attention more recently. So if you go to the next slide, a shout out to Dr. Grace Ryan, who's a recent PhD student in our department, who completed a study looking at missed opportunities. So missed opportunities are a time when an eligible adolescent interacted with the healthcare system at a visit that they would have possibly been able to get an HPV vaccine. We used medical claims to look at this and wanted to kind of see like how many times are kids interacting with the healthcare system before they get a vaccine, or if they don't ever get a vaccine. And in this sample, you can see kids were initiating the vaccination at about like 12 years of age, both for boys and for girls. So looking at medical claims, if you go to the next slide. So looking at the kids who received 0 HPV vaccinations, so those are the non-initiators. They had about 6.5 missed opportunities. Those are times when they saw a primary care provider at a visit where a vaccine could have been administered and these kids were eligible. So kids who aren't getting the vaccine are probably seen, 6, 7 times when there's a chance that they could have been offered the vaccine. And those who actually got the vaccine, those are the missed opportunities prior to initiation. We're looking at like 3.6 to 4 times that they saw providers in the primary care setting at a visit that would have been eligible for a vaccine and did not get the vaccine. So take home message here, there are lots of missed opportunities for healthcare providers to vaccinate kids. We of course want to know what's happening at these visits. Are providers making a strong recommendation and parents are turning them down? Are providers making kind of a weak recommendation that isn't very effective? Or the vaccine is maybe not even being brought up. But that's really kind of a next place for us to be looking. But this is certainly one area, especially during the pandemic, where we can be working with providers to help support them to make sure every interaction they have with an adolescent is an opportunity for them to vaccinate them against HPV. And I would put on my other hat and say also COVID-19. So we know kids are interacting with the healthcare system. Let's get them vaccinated. So if we go to the next slide, we have a kind of scary figure. But we'll break this down to make it a little less scary. So this comes to us from CDC, and CDC wanted to look at what happened to vaccinations March 2020 to September 2020, in kind of the really height of things shutting down and our concern around the pandemic. So they took states who had robust registries, and Iowa was one of them. Their line is the blue longer dash that we then highlighted extra with yellow. So you can see we're really kind of right in there in the middle. And that straight line across the middle, that is the average number of doses administered of the HPV vaccine in 2018 and 2019 for those time periods. And so what you see is this yellow highlighted line, those are the number of HPV administered doses in 2020. And so you can see clearly, in March, April, we're hitting the bottom and we're slowly work our way up to providing a few more doses, but we're still way below the number of doses that were administered in the previous 2 years. And we kind of get up over the 2018-2019 line in August, September. We don't know what things look like now, but our concern is that there's no way they could have rebound. If you think about these kids, that should have been vaccinated March through September that weren't, those are all kids that need to be caught up. And then we have all the kids that are just, becoming 9, 10, 11-year-olds, and they need to be vaccinated. So we've got a lot of kids to vaccinate. So we have a lot of work to do here. Next slide. So we're facing some significant challenges, but we have evidence-based interventions that are really key to moving the style and moving HPV rates. Evidence-based interventions are those programs, policies, interventions that have been shown to be effective. And if you're going to be working in the HPV vaccination space, there are 2 places we think you should check out before you move forward. If you want to go to the next slide, the first one is a National Cancer Institute searchable database that will take you to actual evidence-based interventions, provide you tons of information about these interventions and how you can implement them, connect you to the folks who designed the interventions, a really great resource so that we're not recreating the wheel, but building off of what others have done. And if you go to the next slide, we have the community guide. And so the community guide, you can find it if you Google community guide. And it's from the the Community Preventive Services Task Force. And so members of this task force gather regularly and look at all the evidence around certain types of interventions on different health topics and decide whether or not there's enough evidence to recommend that this is a good intervention and this has got a lot of evidence by it and you should try it, whether there's insufficient evidence or whether you really should not do this is proven to be very ineffective. And so they have one of these analyses for vaccinations, and it really reads like a vaccination playbook, all kind of best practices around vaccinations. And so I also urge you to take a look there before you start reinventing something or going down a path that doesn't make sense. If you go to the next slide, we're very lucky. We're in a state that's been very proactive on the issues around HPV vaccination. We have leaders at the Iowa Department of Public Health who've been involved with the National Roundtable. The American Cancer Society has been on the forefront of working on this in health systems and in rural clinics. The Iowa Cancer Consortium has been leading in this area. Iowa's Medicaid managed care organizations are doing a lot. And we also have a statewide immunization coalition called Iowa Immunizes. And if you have not checked them out, join them. They do a lot of good work around immunization and HPV specifically. I'm going to touch on a few areas where we have things going on in Iowa. It is not by any means everything, but just to give you a taste, to let you know that there is a lot of work going on. This needle is hard to move, and we could use some more folks working on it. So if you go to the next slide, we'll start kind of at the policy level. And I tried to bold the things that were happening in Iowa specifically. So at the policy level, the Iowa Department of Public Health runs the Vaccine for Children's program. If you're not aware of that program, it gives vaccine for no cost to kids. And there's a intervention behind it called the Immunization Quality Improvement for Providers, IQIP. And this is a evidence-based quality improvement intervention that is implemented in Vaccine for Children clinics. And so the Iowa Department of Public Health is implementing this in clinics across the state. We also check the box for having an immunization information system that is very robust and works really well and allows spiders to kind of go out into medical records and collect people's immunizations. It allows people to interact with us. It allows researchers like myself to be able to look at the data. So really important. And we have places like the Iowa Cancer Consortium that provide small grants to implement evidence-based interventions. If you go to the next slide, we end up at the community level. And so we have a number of things going on there. Specifically, I want to highlight that the Iowa Department of Public Health has an HPV vaccination campaign that on a regular schedule gets put out, and you often see those on billboards. And then the Iowa Immunizes Coalition also is doing a lot around communication about the HPV vaccine. Now let's move to the next slide, where we look at like organization at the clinic level. So there's been a lot of focus around HPV vaccine at the clinic level, because if you can change a system or a process in a clinic, you can really get some sustained change that can impact a lot of patients. And so we've spent a lot of time focusing on this area. And in conjunction with the Iowa Department of Public Health, we've done quite a bit of research looking at which of these things are being implemented in primary care clinics across the state, and which ones, have significant barriers, and what we need to do to help folks address them. So reminder recalls, those are those postcards or text messages or phone calls that patients, or in this case, parents, get to say, hey, your kid's due for the vaccine or your kid's due for the second dose. Iowa's Medicaid managed care organization has done quite a bit on this. They've done a postcard campaign and they've done a text message campaign. Scheduling that next appointment before a child leaves the office after they've received that first dose helps make sure we complete the vaccination. And so that's one of the interventions that the American Cancer Society offers to its clinics to make sure that they're improving their completion rates, as well as standing orders. So that's this idea that it should be clear to everybody in the clinic that everybody should be offered the HPV vaccine. It should not have to be something that's decided individually at the provider level every time a child is seen. We also do a lot on provider assessment and feedback. And as Dr. Saslow indicated, you got to know your numbers. And what we found time and time again is that providers have a tendency, like the rest of us, to overestimate their behavior, and they think they're doing better than they are. And when we're actually able to pull the data, either from the electronic health record or from the IRIS system, we're able to say, here's your vaccination rates among the patients that are kind of in your care. Talk to me about that. What can we do to work on that? Let's develop a plan and do like a PDSA cycle and make some improvements there. So that's a really important piece that the Iowa Department of Public Health and the American Cancer Society are working on. And then providing provider reminders. It used to be the sticky note in the chart or a different sticker on the outside of a chart. Now maybe it's something in the electronic health record, but to remind providers, hey, at this visit, you got to get that HPV vaccine in for this kid. So next, will bring us down to the interpersonal level. And so this is really kind of where rubber meets the road. It's where the providers and the patients, or in this case, parents, are having conversations. And so there's been a lot of attention at this level, and a lot of work around developing interventions that are easy for healthcare providers to implement. So making a strong recommendation and training providers on how to do that and practicing that, and using what they call the announcement approach. And these are two things that both the American Cancer Society and the Iowa Department of Public Health have been actively working on with providers, both in larger health systems as well as in rural areas on. And we've been doing some formative research and some pilot testing of interventions with dental providers and with ENTs, knowing that maybe it might not be enough for just your primary care provider to be making that recommendation, but you might need more of a push from someone else, like a dental hygienist or an ENT. So we go to the next level, we get to individual level, and there's been less focus here. But what we have been doing is thinking about provider education. And so we have the Medicaid managed care organizations, the Iowa Department of Public Health and the American Cancer Society have been actively working on provider education. And there are some great client or patient education interventions that are available through that National Cancer Institute website that I talked about. So at this point in time, I am going to say thank you for your time and turn things over to Dr. Schur, and I will be very excited to answer any of your questions when he's finished. Thank you.
So Natasha just highlighted some policies, programs, interventions that we have to promote HPV vaccination in Iowa. And I'd like to take some time to highlight some findings from research that she and I have done that gets into the psychology that underlies HPV vaccine attitudes and uptake. And our hope is that by better understanding the psychology of HPV vaccination, you'll be able to promote HPV vaccines more effectively. Next slide. So the first thing I want to highlight is that most of our patient-facing interventions and public health messaging strategies focus on providing information that we, public health and medical experts think people need to know about the HPV vaccine. And the assumption is that once we get the right information to the right people, filling in any gaps or inaccuracies in their vaccine knowledge, they're going to be more likely to get vaccinated. Next slide. The problem is that these types of interventions have mixed success. And as I'm sure some of you have experienced, sometimes you can give people all the right information about HPV vaccination. They seem to understand it and they still don't want to vaccinate. And why might that be? One potential reason may be due to a phenomenon called the backfire or boomerang effect. And a number of studies have shown that providing corrective information about vaccine myths can successfully reduce beliefs in vaccine myths. However, doing so also reduces vaccination intentions for participants in these studies who have negative vaccine attitudes. So in other words, we can successfully improve vaccine knowledge among those with low vaccine confidence, but at the cost of making them less likely to get vaccinated, which is the thing we actually care about. Next slide. Another possible reason comes from research on the cultural cognition of risk, which argues that we tend to view things that our group views as good, as just being inherently beneficial, whereas we view things that our group thinks are bad as dangerous or risky. And this research has highlighted a kind of a counterintuitive finding that, as you can see on the left side of the screen, this is demonstrated regarding climate change, the risk of climate change. Essentially what's demonstrated is that those who have a higher ability to understand scientific or numeric information are actually more polarized on controversial topics than those with lower abilities in this area. Next slide. So one possible explanation for both of these effects is a psychological concept known as motivated reasoning. And this is just our tendency to seek out and interpret information in a way that's consistent with things we already believe or our feelings or experiences. And it should be noted that this is often happens automatically and unconsciously. It's not, it's not motivated in the sense like I'm motivated to go for a run or something like that. So it happens similar to the way this optical illusion on the screen works. So when looking at the image on the screen, the first thing some of you probably saw is a face, while others may have seen two faces looking at each other. So in a similar way, people might be given the exact same information about HPV vaccines, but interpret the information through the lens of their pre-existing beliefs and attitudes about vaccines. And motivated reasoning is a way that a person with low vaccine confidence can correct a belief about vaccines, but then double down on their resistance to being vaccinated by relying on other kind of negative beliefs about vaccines, which can then produce that backfire or boomerang effect. And similarly, motivated reasoning can help explain the effect with the cultural cognition of risk, where those with greater ability to understand and use scientific, health, and numeric information, they're drawn to that type of information, which allows them to create more sophisticated arguments that support their preferred view on a topic. Next slide. But then this raises a question of, what determines people's vaccine confidence to begin with? What kind of leads to that initial predisposition for or against vaccines? Next slide. And while vaccine confidence is undoubtedly caused by a number of factors, some of my research provides suggestive evidence that developing low or high vaccine confidence is associated with satisfying a person's psychological needs or psychological preferences. And I'll refer to these as psychological motives. Next slide. Psychological motives is kind of jargony, so it's probably not very useful. So I'm going to give you some concrete examples here. So one example would be information preferences. So for some people, they want to see the data, they want to see the numbers and find that compelling. Whereas for other people, they find stories and anecdotes and experiences more informative and helpful for them. Similarly, people vary in how sensitive they are to threats and wanting to respond to threats. Similar, we also see this with uncertainty. Some people, really want to come to a conclusion quickly and just nail it down, whereas other people are more comfortable with uncertainty and can explore it. And then we have achieving social goals. So, this could include things like, the extent to which someone wants to be a part of their in-group, or, their views on, how society should function, whether it should be more hierarchically organized or egalitarian. Next slide. So Natasha and I have conducted a survey with a national demographically diverse sample of a little over 1,300 young adults aged 18 to 26. And while, we clearly have been talking about why we should be focusing on that, 9 to 12-year-old range to initiate vaccination. I still think it's important to spend some time focusing on young adults because it's important to try to get them vaccinated before they kind of age out of that group, where then it becomes even more murky in terms of whether they should get vaccinated or not. So the key results I'll focus on are associations between psychological motives, measures in HPV vaccinations, status and intentions. And I'll note that these results that I'll be explaining here in a second are essentially identical, even if you drop young adults whose decision to get vaccinated was made by their parents. And this first screen highlights factors associated with HPV vaccine uptake. And we found that interest in and ability to use scientific numeric and health information was higher for vaccinated young women. And while information preferences played some role in being vaccinated for young men, we also see closed-mindedness and increased worry about experiencing rare events, which are more kind of intuition or emotion-based motives, were also associated with being vaccinated. Next screen. In contrast, both unvaccinated young women and men had a higher need to deliberate, so they like to think about things. Additionally, unvaccinated young women were higher in closed-mindedness and had higher concern about experiencing rare events, whereas unvaccinated young men had scored higher on increased egalitarianism. Next slide. So you may have noted that some of the psychological motives associated with being vaccinated or not vaccinated were the same across the genders. Next slide. What other psychological motives were higher in vaccinated males, but higher for unvaccinated females. Next slide. And then there's some motives that were unique to certain groups. Next slide. So clearly the associations between psychological motives and HPV vaccination status are pretty nuanced. It's more straightforward for the vaccination intentions among those who weren't vaccinated. So here we see that higher preference for scientific and numeric information, higher closed-mindedness, and increased concern about experiencing rare events were associated with higher vaccination intentions, whereas cognitive reflection, which is the ability to override an intuitive response, was associated with decreased vaccination intentions. And so these results highlight that, while providing accurate information about HPV vaccination is important, a motivation to avoid threats and reduce uncertainty may also increase HPV vaccination intentions. Next slide. So it would be remiss of me to do a presentation in 2021 without talking about COVID. So I'm going to be talking about some data that we've collected recently. Next slide. So this data we collected a few weeks prior to the FDA extending the emergency use authorization of the Pfizer-BioNTech COVID vaccine to ages 12 to 15 years. And we conducted a survey with adolescents and the parents of adolescents. It was non-dyadic pairing. And while the primary goal was to assess COVID-19 vaccination intentions once adolescents became eligible, we were also interested in how parents were thinking about the administration of the COVID-19 along with routine vaccines, given that there had been that dip we've talked about. And obviously the HPV vaccine is included in that group of routine vaccines. So to examine this, we asked parents of adolescents about their vaccine order preferences. If their adolescent's healthcare provider recommended that their adolescent receive a COVID-19 vaccine and had routine vaccines that they needed. Next slide. So on the y-axis, we have all the options that parents could choose from, including not having their adolescent receive one or both of the vaccines. And so one kind of disappointing finding was that only about 12% of parents would prefer that their adolescent receive a COVID vaccine and any needed routine vaccines in the same office visit. So this gets back to what was brought up before in terms of parents maybe having a 2 vaccine threshold that they want in a single visit. And given how challenging it is to get adolescents in for non-acute healthcare visits, if they didn't get them both at the same time, it means there's a greater chance of a missed opportunity for the adolescent to be up to date on all recommended vaccines. Next slide. However, there's some reason for optimism as well. So around 45% of parents said they wanted their adolescents to get both sets of vaccines, but just at separate visits. And around 18% said they would go with what the healthcare provider recommended. So again, this gets right back to the importance of a healthcare provider recommendation. So to kind of provide a quick summary in terms of communication, number one is always start out with a strong presumptive recommendation. If you're a clinician, this can be one of the best interventions or things you can do. Second, try to identify the information needs, but also recognize that information alone is unlikely to change a patient's mind. And then finally, try to identify and address information preferences and other psychological motives that might be related to low vaccine confidence. So, that having questions about vaccine side effects might actually be rooted in, they just might be really sensitive to threats and want to reduce threats. And for them, side effects is the most salient thing. And so by trying to highlight the risk of side effects in comparison to the effects of infection would be kind of what maybe approach you might want to take. Next slide. That concludes my part of the talk, so we'll open up for questions.
Thank you, Dr. Askelson, and also Dr. Scherer for spending your time to talk to the group today. I would encourage anybody, if you have any questions, to submit any through the chat box or raise a hand on the screen. We will try and end on time by 2 o'clock. So maybe I can, I don't see any questions in the chat room right now, but I'll start. This one is for Dr. Askelson. When you showed that graph of the change in HPV vaccination rates during COVID times, what did that graph look like prior to COVID in the 10 to 15 years from when Gardasil became first available?
Yeah, so that graph is number of doses administered, and so it's been going up, right? We've been getting more and more people vaccinated. So I think it was this just significant drop off. Yeah, it's very dramatic. The first time that came out, it was spread like wildfire through our social networks of people concerned about this.
Sure. And I think during that time, that was 2020, that time that you had on your graph, we had a fair number of directives to reduce patient volume in the clinics, and maybe there were just a lot less patients coming to clinic. And then after that, a lot of discussions about vaccines may have prevented it from hitting its prior to COVID baseline. Another question I had, you got some thanks from Morgan Newman for doing all your work on HPV. Given the age with which these vaccines are recommended and the onset of HPV related cancers, at what point would you expect the efforts that are happening in adolescents and young adults to start parlaying into decrease in HPV related cancers? Is that 10 years out still?
So it's my understanding that they're already seeing that in Australia, where they mandated HPV vaccination very early on, and that they're already seeing that drop. I think that there's one, we haven't mandated it, so we don't have the volume of kids protected yet. And we had a pretty slow start. If you remember, the graph that Debbie Saslow shared, we're pretty low, and it's been a slow uptake of 3 to 5% per year. So we got to have a certain mass of people vaccinated in order to, before we can see that.
Good. Has there been any work on the provider side to account for clinics, high volume clinics maybe that are experiencing a lot of stress, to create a billing and coding mechanism to enhance the or facilitate the ability of high volume clinics to have some kind of a reward mechanism for being as strongly worded as we ought to be? Like you said, the rubber kind of hits the road in that provider patient dynamic. Is there anything that happened in that space?
So we haven't seen anything in terms of like billing claims insurance, but we have seen health systems who have challenged their clinics and their providers to meet certain goals, and they have benefited financially, either personally or the clinic themselves. It has not come from the insurer. It has come traditionally from the health system. There might be someone else on this call who would know of an example from an insurer, but most of the time this is coming from a health system.
Last question, and then we'll get off. There's some papers I'm starting to review in lots of different spheres where the education that's being provided to the population is occurring through social media outlets. Are there efforts to kind of educate the public that are going out on social media? And has there been any benefit that you're aware of in this space?
There have been a number of efforts. I think it's really hard when it's at the individual level. And as you all know, there's so much noise around vaccines that this is really something that we need to keep an eye on.
Great, thank you. It is 2 o'clock, so as promised, we will let people get off for the day. Thank you all for attending. Thank you to all of the presenters and the participants. Please check the chat for information about evaluations, and we will see you all tomorrow for day 2.